Hello. We're here in Orlando, and we've been actually attending the GU ASCO meeting, and we're just wrapping up the prostate cancer sessions. We're actually on the second day of the meeting, and we thought it would be a good idea to actually recap and share some of the thoughts that have come to mind after the presentation of several of the abstracts. I'm here with Dr Payne. Heather's, I would call you a good friend, I hope. Clinical oncologist. We actually share some patients from London. She's a professor in the University College of London. And of course, Chuck Ryan. He doesn't need any introduction either. And Chuck Ryan is from the University of California. He's a professor of medicine as well. We're all in the medical oncology field. But Heather, on top of it, is also a radiation oncologist. So we are really wanting her insight today, given what was presented during this meeting. It was a diverse meeting. I think we got some information across the stages of the disease. And some of it was, there were several posters that didn't really get the chance to be presented at the podium, but were probably noteworthy. So Chuck, you actually, during our discussion, mentioned something regarding
Sure,
screening.
I mentioned a couple of posters that were important, we thought, for the general public. One had to do with a potential for an increased risk of high-risk prostate cancer associated with the lack of PSA screening in the United States. I think it's a little controversial, it's a little early, but it was nevertheless an analysis from the SEER and other databases presented by an author from the City of Hope that demonstrated that there may be an inflection, there may be an increased number of patients in the United States who are being diagnosed with high and intermediate risk prostate cancer, and that this inflection may have occurred after the time when the U.S. Preventative Services Task Force recommended against PSA screening. So far from settling the issue, it just makes it important that we continue to monitor the incidence of localized prostate cancer and the risk factors associated with it.
So actually, this is an important point from you coming from Europe. I'm just between the two continents, and I will not comment on it. But would you like to actually take a stab at that? What is your feeling?
And I think obviously living in a society where we've never had prostate cancer screening, it's quite interesting because it's like ripples in a pond, that you see a man who has prostate cancer, and more men are coming forward in the UK because of sort of charities and because of their experiences with members of families and friends to get tested. So I find that fascinating because it's something that I know that many groups in the UK are working very hard to have a proper screening program, and obviously this is.
Yes, so we'll have to wait and see.
Yeah.
It's a little early to know what that means. And then the other factor that came across related to localized disease was the issue of active surveillance in an intermediate risk cohort. And this is an area of controversy. I think there's a relative consensus building that many patients with low risk disease do very well on active surveillance, and I think it's less controversial than it used to be. However, intermediate risk disease, PSA is greater than 10, Gleason 7, et cetera. There was a very interesting presentation from Dr. Loblaw from Toronto where they looked at their database over the course of 15 or so years and found that there was a substantial proportion of men in the intermediate risk cohort who went on active surveillance who subsequently died of prostate cancer. So again, it makes us think twice about this group, and it calls for more research on molecular markers or other things that might tell us what are the differences in potential outcomes for patients with intermediate risk localized disease.
They're a huge group, aren't they, intermediate risk?
Well, actually,
I mean,
I'm sorry I interrupted you, but you just really led us to the next topic, the presentation of the 4K score. That was something that created a lot of discussion following the meeting. It seems like a low-hanging fruit, an easily assessed signature combining the PSA readouts, the digital rectal exam, and some other phenotypic mainly characteristics. So this is an old story that's coming now probably to fruition,
Right.
But what would you anticipate to come off it?
Well, as with every intervention or test or anything, it needs validation and a big study and sort of a definitive endpoint. And the question always in localized disease is, what are we going to look at for the definition of clinical benefit? Is it reduction in the risk of death from the disease? Well, that's a long-term proposal that's going to take many millions of dollars to test in many centers. Or is it decrease in the burden of treatment, et cetera? So it's interesting. We continue to hash away at these very interesting issues related to localized disease.
Your thoughts? Do you think that it actually performs well? I wasn't really happy with the performance of the test.
It needs further investigation, doesn't it, really? But it's
Probably
this is
enhancement
me.
with better
Yeah.
molecular predictors
Yeah.
in circulation or what
Yeah.
have you.
Yeah.
So actually that brings us to your domain, the intermediate risk disease. There was a little bit of a misunderstanding while the presentations were going on, whether we were actually being presented with data that were referring to high-risk disease or more so intermediate disease, localized, of course, when it came to radiation therapy treatments. And we saw results from 3 different studies, some more interesting than others, some, as we discussed earlier, addressing more minor issues, but of course of importance. So what would be your expert opinion in what was presented?
I think firstly it was great to see radiotherapy up on the stage and to have that data
A lot of it.
presented, a lot of it. I think it brings several sort of principles to light, really. You know, one is that we need better surrogate outcomes for radiotherapy, but especially if you're looking at low and intermediate risk disease. In fact, some of the patients in all of those studies would maybe now have active surveillance. And so looking for small differences, you're going to have to follow them up a long time. And to me, I think it was a shame that some of those studies weren't looking at the real high-risk patients, because they are the group who most likely dose escalation is going to make the biggest difference because they die from their disease. They're more likely to have extracapsular extension, they're more likely to have microscopic metastases. But I think the sort of take-home message from all 3 papers were that you do need multimodality therapy. And I think it was a great relief for all of us who've given hormones with radiotherapy for intermediate and high-risk disease for many years to see that that study did actually show that was the best group. And I think we haven't heard the end of dose escalation. And I think for those high-risk patients, brachytherapy plus external beam is an attractive option. And I agreed with Dr. Martinez that high-dose rate brachytherapy, I think, has got a big part to play as dose escalation. That's my standard of practice, is HDR boost, good doses of arcing therapy or IMRT to the pelvic nodes for high-risk disease in combination with hormones. And I think the big question is where surgery fits in as well.
You actually brought up a great point. The urologists were quite happy to see the data because they actually think that they can, if needed be, intervene more after brachytherapy, but of course they're waiting for their data set.
Yeah.
What are your thoughts?
It's control of the primary, and I
Right.
think, you know, even in the medical oncology circles, we're beginning to talk, and I know you are thinking about this at your center as well. Even in patients with oligometastatic disease, treatment with radiotherapy or even radical prostatectomy, while it might have seemed crazy previously, there's now enough data kind of emerging to say we need to rethink this, and maybe this is a situation where we can, by controlling the primary, we're going to affect outcomes positively across the board. And, you know, maybe there's a subset of patients who even present with locally advanced, even small amounts of metastatic disease who we can cure. Still very investigational, but you hear this kind of conversation happening around data like this.
And you've got to be pushing it forward, haven't
Yeah.
you, for these guys? I mean, the STAMPEDE study now, we're irradiating
Right.
randomized prostate radiotherapy versus no radiotherapy for people with multiple metastases to see if that's going to have an impact on future bone mets.
But having had the discussion with you earlier, you did bring up the fact that we have to wait for such a long time. And you just told me that you're getting proton therapy in London.
We
as
are.
well. We've been waiting for 10 years for these results. I mean, do you think that we'll find some surrogate endpoints to use for these specific treatments? And this is outdated technology in some of the presentations used, as you pointed out.
Absolutely. But I think the group who benefit most are the high-risk group. And I think they are the ones where you'll see 5-year differences. And they are the patients who are going to relapse a lot earlier because they have such a high risk of microscopic metastases. And you stop their adjuvant hormones, and a lot of them are going to relapse very quickly. And you can, you know, sort of looking at the BOLA data, there was a difference of 5 years, wasn't there? And all the big sort of radiation and hormone data, you saw sort of earlier good outcomes from them. And I think in this group, PSA is actually much more important than in probably the castrate-resistant patients, because PSA recurrence does mean something after radiotherapy and hormones. So biochemical progression is something that we can look at, I think, in this group as a very valuable endpoint.
That's a great point. Before we move forward, I wanted both your opinions on Anthony D'Amico's presentation. During his presentation, he went a little bit back and forth on the issue of androgen deprivation for high-risk disease, presenting a little bit controversial data on whether it should be implemented more so or whether these cases would be more resistant eventually. And we haven't even brought in, as you said earlier, neuroendocrine features, even proliferation indexes. Where do you think the field is going to move? Because the unmet need, as you pointed out, is high-risk, locally advanced disease right now.
Well, I think what I took from Dr. D'Amico's talk is that the data on 18 months of hormonal therapy is suggestive, and it's moving very, very close to looking like it's definitive. Is that fair to put it that way? And I think he was saying just needs a little bit more maturity or something was his term to say before we can consider this the definitive approach. This concept of whether longer hormonal therapy might create a more resistant phenotype down the road has always been there, and we just don't know. And I think that a couple issues around that are, one is we're learning now a lot about what that resistant phenotype is. I just don't know how we can apply it to this this conversation about locally advanced disease. And also, the trials are so complicated by all of the subsequent therapy that patients get, which is something we see in metastatic disease, and make it difficult to analyze some of the long-term outcomes of these studies, I think, at this point in time.
I feel really strongly about adjuvant hormones with radiotherapy. And I think, some of the early, the 8531, the Boller study, 9202, they were before lots of further treatment. So I think you're seeing pure data in that. And also, you had an overall survival benefit.
In multiple studies.
10 years, yeah. And so an overall survival benefit at 10 years has to be the best thing to do. And okay, some men are going to relapse, but if you're actually curing a group of people, then I think you have to go. And if 18 months is now as good as indefinite versus 3 years versus 2 years, that's fantastic. Because obviously you don't want to give them all the morbidities of hormone therapy if there's no need. But I think you do have to have adjuvant treatment. I think you do need multimodality therapy.
Great. Moving on to the negative studies of the meeting, and there were several that were presented. And in the same disease group, locally advanced disease, the Scandinavian group presented the final analysis of their bicalutamide 150 milligrams versus placebo. And of course it was a negative trial, and we also discussed it earlier as probably anticipated. What's in general your view moving forward with the issue of bicalutamide, and what else is there to expect out of bicalutamide?
Well, I don't offer bicalutamide as monotherapy for somebody with locally advanced disease. It's never been something that I've even thought of, and that was based on the data from 15 years ago or 12 years ago, which showed an adverse outcome in that group of patients. And so this is a confirmation of that, and I don't go much further in that conversation. And it also brings up the issue of controlling the primary versus not controlling the primary.
I use a lot of bicalutamide, actually, that's just monotherapy, probably because I was involved in the EPC studies. And I think if you looked at those studies at the beginning, obviously when they were designed, things had moved on when you were looking at sort of 10, 15-year data from EPC. But I think if you looked at the beginning, the only group where there was going to be a survival difference was adjuvant to radiotherapy, as we were just saying. And certainly locally advanced adjuvant bicalutamide, there was a survival advantage for that subgroup. The other groups, there was never going to be a survival advantage. And in fact, I think for the localized group, giving them, they didn't need any treatment at all. So if you give somebody who doesn't need treatment at all a treatment, there's going to be more toxicity than there will be benefits. But I think there are advantages, certainly adjuvant to radiotherapy or with locally advanced disease itself, is that men don't lose bone density. And certainly for some of the older men, that can be a big issue. They keep more sexual interest, and some maintain erections. So I think there is a place for bicalutamide.
I believe there's a place for it, for sure. What I said, I meant to, just to clarify what I said, I don't give it in place of local therapy or as the primary therapy for anybody. Yeah. But we use it, for example, in certain patients who wish to avoid castration-based approaches in recurrent disease, rising PSA, et cetera. And I believe it to be a fairly safe treatment at low cost, et cetera.
We often give it concomitant with prostate bed radiotherapy.
Yes.
Because that young group of patients, and there was the 9601, wasn't it? The study looking
Correct.
at 2 years versus no bicalutamide, and so we tend to follow that.
So it's quite interesting, though, if we were to project how such data would look in light of enzalutamide or ARN-509, and I think it just raises more of an interest towards that point. We're moving on now to the metastatic, purely metastatic disease, another negative trial that was updated. It was actually a nice spin that they gave to it. Dr. Gravis presented the analysis of JTUG, the follow-up. It's a more mature study now, and also did a post-hoc analysis applying the Chris Sweeney, let's call it, classification. It's the GLASS classification. And it changed a little bit the percentages of high-volume disease in that trial. It came up to 50%. No differences even in the post-hoc analysis. I think Eric Small did a terrific job reviewing it, and I wanted to get your thoughts on that and how he put it across the Sweeney data.
Well, the fact that it certainly throws into question the ECOG data because there was not a significant difference seen in the high volume cohort of patients. So it's certainly not the confirmation we would have maybe hoped for. But it was, I think, reaffirming that, actually that study, that group of patients in France had a much longer survival than the ECOG study. And so that's what Dr. Small kind of threw into the question here, which is, maybe these patients weren't as matched as we would think.
And your thoughts? We're waiting on
We're
something.
waiting.
We're waiting.
I mean, obviously, we're waiting for Stampede data. And
Hopefully.
I think it was hinted that all the data might be put together, wasn't it? And looked at.
Oh, that'd be
Hopefully.
great to see those two studies,
Yeah.
the data combined, and if it's possible.
We were discussing earlier with other colleagues from countries in Europe that we can't even really use docetaxel earlier in hormone-sensitive metastatic disease based on the guidelines and the specification of some of those countries. So we desperately need first to see the published data, and we also need to see the Stampede data.
It's really important to point that out with the ECOG data. It looks very impressive, but it hasn't been published yet.
Yes,
So.
yes, of course. Hopefully very soon.
And I mean, certainly my practice is that if somebody's PSA isn't going down quickly on their first line ADT, then we'd add docetaxel in
We do, don't
very
we?
early,
Like,
within sort of 3 or 6 months. And
it's in our algorithm,
Yeah.
essentially.
and that was sort of different to the study, wasn't it, where it was a more sort of delayed addition.
But it was interesting what you brought up. Eric Small pointed out that the only 30% of that cohort on Chris Sweeney's data set actually received docetaxel
For CRPC.
for CRPC,
Right.
and that's important, and how much of it.
Yep.
Very interesting analysis, and I really asked him for his slides immediately.
Yeah.
So
Hopefully I
moving-
can get them too.
Oh, so moving on, cabozantinib, the big negative data that we were all hoping to be different. Big New York Times spreads on how it changed the characteristics on imaging. Your thoughts? Would you like to tell us first?
It was very disappointing, wasn't it? And I think it was the drug for the future for the last few years that people have been sort of waiting for the data from the two studies. Again, fantastic presentation. There was just those sort of little hopeful moments that there may be subgroups of patients who are going to benefit from the drug, and also I guess the whole dosing issue. That that maybe if the dose had been a bit lower, people would have carried on because there were significant toxicities.
Right. It's, I think most of us who've used cabozantinib, myself included, have seen responses, have had sort of a belief or a feeling that it was benefiting patients. And I think there's always two questions that come up in studies like this. One is, was the patient population too advanced in light of the availability of enzalutamide and abiraterone and cabazitaxel? And number two is, was the dose correct? Some of the initial studies were at 100 milligrams, and many patients are dosed at as low as 40 milligrams. And so we don't know. We'll probably never know. I don't think there's a plan to have another study, in a phase 3 study in this patient population. So we'll have to see. And it is a disappointment. What I always liked about cabozantinib as the story had evolved was that it wasn't a hormonal therapy. So it had the potential to either interact with the hormonal axis, or it had the potential to be available for those patients who immediately fail the enzalutamides and the abiraterones of the world.
So a tumor microenvironment agent that doesn't find its place, even though the biology is in line.
Yeah.
And don't you see a pattern? We're going in the past couple of years through negative trials. Where's the failure? We're failing after all this wonderful drug development.
Well, there's a number of reasons why trials could fail, and we could talk about this for the rest of the day if you want. But
just a couple of things.
I would say that number one, the need for overall survival to be the primary endpoint. I think that was appropriate 5 years ago, but it may not be appropriate anymore. And so we can't restrict what patients get after progression on a therapy in one of these trials, and so we need to have a surrogate endpoint. The study that I published and others have demonstrated that we can develop a primary endpoint of radiographic progression-free survival. So that's something that we would hope to see incorporated into some of these studies. Some of this has to do with regulatory structures in various parts of the world that demand survival differences. And that's a problem and a challenge that we face in the field.
Actually, I would chime in saying that we need to be a little bit more selective in the populations we now.
Absolutely, yeah.
And we're not even close, probably. Just a
Right.
couple of trials coming up that will try to do that.
Right.
And that brings us to actually the data that you presented during this meeting. And it follows, of course, the recent presentation of ESMO of the updated analysis. And that gave us a lot of lessons to be learned. And in fact, the wonderful thing about androgen signaling inhibitors is now we have 4 trials in line,
Yes.
which is the best you can
Yes,
get.
exactly.
So tell us a little bit about
Well, I would
your
say the
data.
headlines are basically that now we have the Cougar 302 study has gone through demonstrating a radiographic progression-free survival benefit, an overall survival benefit which didn't emerge at the second interim analysis that was presented and published 2.5 years ago. But the overall survival advantage was there when the data was fully mature. And this reason, there's a variety of reasons for this, but the data we presented today looked a little more closely at the issue of crossover. So in the placebo arm of the Cougar 302 study, 44% of patients received abiraterone at some point in their lifetime. And it could have been post-docetaxel, it could have been on protocol right after they came off placebo. That was only 9% of patients. But the point is, these trials in which we think it's randomized and there's 2 different arms, there's a lot of crossover that happens in many trials, and I think this trial was a great example of that. So the data we presented was a statistical exercise really that looked at what would be the expected survival of the placebo patients had they not experienced abiraterone exposure. And with the analysis overall, the hazard ratio is 0.81. That's the final data, statistically significant. But when you add in the iterative parameter estimate, which is the statistical methodology, the hazard ratio drops to 0.74. So, that's a post hoc analysis, I fully grant you, but it does help us to think around this issue of how much of an impact crossover has on survival in these kinds of studies.
I lost you when you put in the stats, but would you now say that earlier is better?
Well, we've known this for a while, that the patients with earlier phase disease have
Right.
better survival, and that's emerged from a number of different studies. And so, yeah, when we've looked at, for example, baseline PSA by quartile and those kinds of things, we see longer durations of benefit and preserved benefits over placebo.
So I'm specifically speaking with regards to androgen signaling inhibitors because I'm just going to try to move into the splice variant presentation with that.
Mm-hmm.
My personal view is earlier is indeed better, but we could have bias. I think your data supports it 100%. Is what Bertrand Tombal said. It actually has its own control in there to compare. But let's go into Emmanuel's data set. Emmanuel and Genetics and Jean-Louis just presented us some very interesting and provoking data, I would say provocative, with regard to the impact of taxane treatment on patients whose cancers harbor or not ARV7 splice variant. So your thoughts and of course, I guess for the audience, a summary of what you said.
Well, the V7 is essentially a mutation of the androgen receptor that renders it able to signal without the presence of androgen. And at ASCO and in the New England Journal of Medicine, he showed that those patients who have circulating tumor cells who have that mutation are unlikely, almost 0% responded to enzalutamide or abiraterone. And that makes complete biological sense. It's a nice story. There's some questions about the assay and whether or not, there's some methodological issues that still remain questioned. But what he did now, which was the next question that came up, was, okay, we know that those drugs don't appear to work, but what about the other stuff like chemotherapy? And so he showed that cytotoxic chemotherapy with docetaxel and even some cabazitaxel patients appeared to benefit at a rate that is pretty much with what you would expect from historical controls with the V7 negative. There was a slight difference in the V7 positive versus the V7 negative patients in terms of the response to docetaxel, but they were both within a range of what we might expect. And so I think that for the clinicians out there, should the V7 test become something you can use on a regular basis, it should be something that could potentially select away from the use of the androgen axis drugs and select towards chemotherapy earlier rather than later.
Your thoughts, Heather, on how that data was presented and what your take-home message would be, given that we do not have access to ARV7 assessment?
I think it's probably one of the big hopes for the future, isn't it, really? Coming out of this meeting, there's been a lot of data which has consolidated or confirmed things that we thought. But the big question is always going to be sequencing, isn't it? And to have a piece of information which may help you sequence in a sort of scientific and rational way I think is a big hope for the future. And that's where we would hope that personalised medicine is going to come in and that we're going to be looking at more and more stories like this.
And I would add, Eleni, that you and I know this, we all know this, that credentialing a drug through a clinical trial is a very difficult, labor-intensive, time-consuming process. And what fewer people appreciate is that credentialing a biomarker is equally laborious. And we don't want to get too enthusiastic about this V7 story yet. This was an academic lab running this, and great center, great lab, great investigators, all of that. But the question of whether it's applicable, its universality and its reproducibility in how we handled the specimens and things like that is another important question. And I think that's one of the challenges that group has over the next years, and we as a field have, which is to validate that data.
Actually, you brought up a great point, because we all remember the time it took and the presentations we've seen over the CTC Veridex platform, and how Howard Scher has really persevered through the years to get it there. It's my only, and actually Emmanuel brought it up at the end of his presentation, my only slight concern was that these were only 37 patients that were looked at. I would be very reluctant to come to any conclusion from the final graphs that we're showing, putting all these patients against the Abi-Enza. And this was not, it was a prospective study of the biomarker, but not a prospective study of the agents performed. So I think we'll need to look very closely, because the p-values are strong, but we need to look at the details. So final comment, I really like the story on the anion exported in the association of statin use with a delay of time to PSA progression. Phil Kantoff presented, and it was very elegantly done. Your thoughts? Is there something we should be looking for?
Yeah, these are very common questions we get from patients about available agents, statins, anti-diabetes drugs, and those kinds of things, and could they benefit patients? And there's a series of analyses that seem to kind of all be pointing in the same direction, that statins may have a benefit, and I'll throw metformin in there as something that's frequently discussed. And so all of this, for me, begins to point to the fact that for many patients, not all, but for many patients, advanced prostate cancer is a metabolic disorder. And it's a metabolic disorder where there are steroids being made, there are other intratumoral metabolism events that are happening, and it is possible that some of these available agents could actually be integrated into sort of the standard of care. They suffer the problems of everything else too, which is validation and appropriate trial designs and things like that. So, I'm a little bit conservative and sort of not recommending all these different therapies for patients. I don't put patients on statins just because of what I see at ASCO. I put them on statins if they have hyperlipidemia. But anyway, that's open to question and may change over time.
Heather, I think that Stampede is trying to address such
Absolutely.
issues.
I mean,
So-
Stampede just rolls on, really. With them
That's why they
more
call it
and
Stampede.
absolutely, we're stampeding through prostate cancer. It's fascinating, isn't it? I mean, it's quite unusual for me to see a patient who isn't on a statin. Actually, that's the only thing that the majority of the patients in my clinic are already on a statin.
Yeah.
So, but they're keen to carry on now.
So we started off on a good year on prostate cancer therapy development, I think, with GU ASCO. More to come in a month, European
Yes.
Urology meeting, and then on to ASCO. Thank you very much for joining us.